Namaste and greetings. I, Tanu Palibal, researcher at IMPRI, Impact and Policy Research Institute, Prabhav एवं नीति अनुसंधान संस्थान, Nai Delhi, extend my warmest welcome to you all to IMPRI, Web Policy Learning. Today marks the inaugural day of Health Sector Management and Governance, an Indian perspective, an online national summer school program, a 1 month immersive online certificate training course. This training program is organized by IMPRI, Center for the Study of Finance and Economics, IMPRI, Web Policy Learning. Let us begin with an overview of this program. The COVID-19 pandemic exposed significant gaps in India's healthcare system, highlighting the urgent need to address these issues to ensure the country's economic and national security. Consequently, health sector management is now viewed as a profession rather than merely a welfare activity. An effective healthcare system is essential for making the population resilient to changing environments and future pandemics. This shift aligns with India's collective vision of Viksit Bharat by the end of Amrit Kal in 2047. With a healthy population as one of its aims, in this context, the program is designed to enhance health management literacy among policymakers, administrators, students, and professionals involved in public policy and governance. It covers essential topics for effective health governance and fosters knowledge sharing and networking through its interactive online platform. This online program has an excellent panel of experts who will be sharing their expertise for the duration of this program. The expert panel includes Professor Mukul Ji, Mr. V. Ramakrishnan ji, Dr. Parishram Patil ji, Dr. Manorama Bakshi ji. The panel of conveners comprises of Dr. Simi Mehta ji, Dr. Arjun Kumar ji. The chair of the program is Professor Mukul Ji, former professor Lee Kuan Yew, School of Public Policy, National University of Singapore, visiting distinguished professor IMPRI. Proceeding further, I welcome all the participants to this enlightening deliberation and thank you for being interested and putting your time, energy, and efforts into learning, sharing ideas, and contributing to the ever evolving landscape of healthcare management and governance. We have also shared the course outline and reading resources in your email. Before we start today's session, I would like to remind the housekeeping announcements once again. Please join the meeting on time. There will be question and answer session after each presentation. Share your questions on the question and answer box. The questions must not be posted as an anonymous attendee. Ensure that your questions are precise. Refrain from making any general comments on the question to save time. Now, without any further delay, let us start with our program. It is my honor and my privilege to invite Professor Mukul Ji, former Professor Lee Kuan Yew, School of Public Policy, National University of Singapore, visiting distinguished Professor IMPRI, to give his kind remarks and an introduction of the course to our participants. We welcome you, sir.
Hey,
Sir,
Namaskar. Pranam to everyone. Let me share the screen. Can you all see the screen? Hello?
yes, sir, it is visible.
Okay. Let me begin by congratulating all the participants for their interest in the health sector management and governance. We know that the general principles of any discipline in economics or others, they are more or less universal, but the application of those principles is contextual. You have to understand the local context or a domestic context to see how to use it. So what we have titled this as from an Indian perspective, we would like to look at the health sector management and governance. This is an area where we, as a country, need to develop a lot more expertise because in the past, professionalization of the health sector management and governance was not given as high a priority as perhaps was required. Even today, there are some health organizations where the uh, importance of management training, technology, ERP systems, management information systems, and so on, uh, is an area where there is good scope for improvement. Now, the central premise of our 4-week program is that the COVID-19 pandemic has vividly demonstrated that a well-functioning, accessible, uh, no use having great hospital in the big cities if it is not accessible at the district level, town level, and so on, and affordable healthcare system. Notice I'm using the word system because that system will include both the preventive care and the care when somebody is sick, and will include both communicable diseases and non-communicable diseases. So this is an imperative for economic and national security and for social cohesion. So those countries that didn't manage COVID-19 pandemic, unlike India, which managed it well, they are still having these problems. Health systems are complex and they require continuous trade-offs among accessibility, affordability. Affordability has to be to the individuals, to the employers, fiscal affordability, budget, society. It has to be affordable by the society as well. There is no country so rich that can say, I give you the best healthcare for everything. There's no, the resources are simply not there. Particularly as healthcare technology is rapidly evolving. And this is something new. The digital technology, for example, telemedicine, others, and so on, and the uh, uh, new types of manufacturing, additive manufacturing, have really changed the healthcare sector. There has been a tendency to medicalize social problems. You know, as the support from within the uh, joint family system, within the community, as that becomes less, the socialization of the medicalization rather of the social problem, that tendency is very much more prevalent than before. And that has to be recognized. For example, we are now recognizing mental health as an issue. So many young people today, they have to go to the counselor uh, and so on, which was not the case 3 generations ago. Okay. So the program is predicated on the above premise. Now let's look at what the constitutional provisions are about the health system. The delivery and financing of most healthcare services in India is not a federal, but a state government responsibility. This is something that is often missed, and we haven't developed the state level health management, uh, health economics, uh, research centers, others that we need to do. And we have not held the states accountable for their health policies. Instead of the focus has been on the center. There are wide variations in health indicators, income, development, healthcare infrastructure, and health outcomes across states in India. And we need to understand that granular type of data. So this is data management. And now we have got the computer technology to manage large data. That is something that has also been often neglected. So I'll give you one example. One time I was a consultant with ESIS, the Employee State Insurance System. And in Delhi, I was with the Director General. And the Director General asked me, he says, I need to improve the efficiency of my healthcare delivery systems. Where should I start? I asked him the following question. I said, you have just told me that you have more than 130 hospitals, ESIS hospitals across the country. Now tell me if there is a very standard knee procedure, medical procedure or knee problem. What is the per unit cost of that knee medical procedure across your 130 hospitals? He looked at me, he said, I don't know. So I said, your first priority, if you want to improve the efficiency, is clear. Set up a robust database system for management information where you can look at the data and then try to decide your priorities, try to see what is needed. You can't go physically to 130 hospitals and really get any accurate picture of what needs to be done. So that was something that ESIS had not done up to that point. This was a few years ago. The Cooperative Federalism Initiative since 2014 aims to transfer a greater share of current and future responsibilities, along with accountability to state government. So we need to pay more attention to the state level. India's health system evolved gradually with limited coordination. Ministry of Labor until recently supervised two major health programs. Why would Ministry of Labor know anything about health? Why not give it to Ministry of Health? The Ministry of Labor still continues to supervise ESIS, which are health benefit scheme for designated private sector employees. It should be transferred to the Ministry of Health so we get system-wide coordination. Some tools used to organize the system are not used with their institutional prerequisites. And the ESIS and EPFO, for example, don't have a professional fund management. ESIS doesn't have a management information system that can tell them about how to make good management decisions. So it's a complex area, involves a lot of things, and we shouldn't make offhand judgments about the whole system because the state level variations need to be taken. Now, let's look at how we will organize the program. When I do a program, I usually try to find some relevant thoughts and insights which are relevant for the program at hand. So we'll start with some of those. We'll look at poverty rate and inequality trends and their implications for the health demand that's going to arise. Select demographic indicators and implications for the health sector. Then integrative local context specific initiatives that impact on health. If you look at it in a more integrative way, a broader way, rather than say, oh, just build a hospital, cure them, and so on. You can't, that's not just healthcare, it's a system. And there are many parts to it. The complexity, we have an article that says, that will explain what those complexities are. And then the program structure, I'll explain why we have put it together and who the people are. Okay. Relevant thoughts. I'll start with Hindi, if you permit me. I'll translate it in English afterwards. इस बात का बहुत ध्यान रखो कि आपकी जिंदगी के जहाज पर कौन कौन सवार हो रहा है, क्योंकि कुछ सवार लोग आपके जहाज में इसलिए आए हैं, वो उनको डुबाने की कोशिश करेंगे क्योंकि वो जानते हैं कि वो कभी कैप्टन नहीं बन सकते. So basically the idea is that who do you associate with? Who do you refer to on WhatsApp, on others? And which are the people that are closer to you and you let them become close to you? That has got important implications for pursuing healthy lifestyle. If you are with friends who like to drink, smoke, eat gutka, this, that, how are you going to get a healthy lifestyle? Or if they don't eat well, eat irregularly, others, and so on. So this is very much more important now than it used to be, because we are living longer too. And that all these things do add up and show up once you are above 60. Okay. I'll move from Hindi to Sanskrit. Ano bhadraha kratavo yantu vishwata. Now, what does it mean? सभी दिशाओं से ज्ञान को आने के लिए अपने मस्तिष्क को खुला रखिए. So that means keep your head open to get knowledge from all sides. Don't be rigid. Rigidity in thought, oh, I know. Okay? Many people don't even know their bodies well. And you find that out, when somebody tries to teach you how to breathe. What does short breath, long breath, others, they mean, you know how little you know about your own body. So rigidity in thought would prevent essential relearning about health at individual, organizational, and policy levels. Can't be rigid. And what has often happened is that there are some preconceptions about health, and they are never re-examined to see how far valid they remain. One more, sarvasyo damastit shastra vihitam murkhasya nastayo shraddham. There is cure for everything, but not for foolishness. So healthcare system, while we are learning, it has a lot of personal thing about how to live a healthy lifestyle. that's going to be increasingly critical because healthcare cost inflation is much higher than the headline inflation. So that the less you spend on health, the better your living standards are going to be. So in one's own interest to have a healthy lifestyle. This is the year of the millet. So the millet are healthy compared to rice and wheat and so on. But how many people know that? And even if you know that, how do you translate it into action? Okay. These are thoughts on personal health by an Iranian intellectual from Iran called Wala Afsar. Do not take your good health for granted. Be selfish about your health. All these could help a person live a healthier life, minimizing healthcare expenditure. And I said healthcare inflation is high. Healthcare expenditure as a share of household budget increases for those above 60 years of age. A lot of people wonder, why do old people talk about health all the time? Because it's a very large part of their household budget that medicines, others, and so on. So what does Walash Afshar say? Read to improve your writing, write to improve your thinking, speak to improve your storytelling, build to improve your understanding, give to improve your networking. This is general. Now health related. Move to improve your healthy living. Walk, move. Sleep to improve your mood, and smile to improve your happiness. So all these personality traits that sound small have large implications. People confuse sattvic life with food, only food. Sattvic life is a way of living. It is like riding a wild, plundering horse, which is mind. No, mind never stops. So controlling mind is very, very important. If mind has got good thoughts, constructive, positive, problem solving, that is very important, and controlling it. It's the highest way to live in the world, to be calm, simple, and serene. And this first step in yoga too. So part of the can relate it to health. Now we move from individual to more broader aspects. Interesting. How much bad news is anecdotal? Oh, this happened to this guy, this happened to that guy. Bad news. And good news is statistical. And very little understanding of statistics. So to get good understanding of healthcare system, data and numerical statistical literacy is essential. So health statistics, health data, others should be part of any program in health policy. So still, if only one of the two can be good news, I would rather be statistical. It accumulates towards qualitative change that lasts. Anecdotal doesn't, and we have to be very careful. Today's, instant age with WhatsApp and others, it's very easy to become anecdotal. Now we look at the poverty rate and inequality trends. I have taken this from article by Karan Bashin and Surajit Palla, just published. They have argued that the headline poverty estimates are consistent with earlier findings of near elimination of extreme poverty in India. These estimates are without imputation of in-kind benefits, which would further reduce the headcount ratio. So now, India, never say, oh, India, poor country, third world country. We have eliminated extreme poverty. Our problem is going to be malnutrition, lack of knowledge about how to eat, what to eat, when to eat, what to do. And it's going to be about the middle class concerns on healthcare. And so we will have to deal with communicable diseases, which whose share will go down, and the lifestyle diseases will go up. Lifestyle diseases are more expensive to treat. They don't make people die soon. You can still live. We have diabetes, fine. You can, it's expensive to treat diabetes, but you can live for a longer time. And now that is the kind of India as a middle class society is what we need to think of, not India as a poor society. They argue, the Bashir and Bala. First, the Tendulkar poverty line is now obsolete in India, and therefore India should graduate to a higher poverty line. This is the standard practice that several countries routinely revise that poverty lines based on expanded definitions of deprivation. So what is it? It's not just basic food or housing, it's more than that. Given the large decline in poverty headcount ratio in India at the $3.2 PPP poverty line, we argue that India needs an even higher national poverty line that adequately measures deprivation. So by that definition, poor will always be with us. Okay. But the thing is what level we define, how we define, what we do to try to reduce that number dynamically. Second, the rapid decline in poverty levels also necessitates a broader discussion on national poverty alleviation programs, particularly as there is a gradual need to transition towards a more comprehensive social safety net. So you have to look at India's Jan Aushadhi program, where we get generic, low-cost medicine, benefits particularly the middle class, lower middle class, and middle class. The Ayushman Bharat, Ujjwala Yojana, Poshan, other kind of schemes, which will be explained later by other resource persons. We need to think of it in a broader context. The inclusion of imputed value of in-kind transfers. We need to take that into account. We can't just look at money income because there are imputed income that are also present. It provides a unique opportunity to policy enthusiasts, scholars who are exploring the efficiency of these transfers along with their welfare implications. So this is a research agenda for the those in the healthcare field that they would explore. Elimination of extreme poverty and reducing inequality both will increase demand for healthcare services, including medicines. So I said middle class concerns. And India will need to manage both communicable as well as lifestyle diseases. Here is the graph. Now notice that this is the extreme poverty line in blue. In 2011-12, 12.2% was the headcount ratio of the extreme poverty. This is 1.90 PPP per day. Today it is 2%. So it's eliminated. But if we take higher level, 3.20, it was 53.6 in 2011-12. It has now been in the teens. Okay, so we need to look at now the basic poverty, extreme poverty is not a major policy issue. Unfortunately, the political parties, the policy makers, others still continue to put on extreme poverty. And we need to create, that's why the literacy in healthcare, health system management, governance is very much needed. Now, which are the states that have reduced the poverty rate significantly? Bihar. We think of Bihar as a hopeless case, but it has done a very good reduction in poverty rate. Uttar Pradesh, UP is coming up in different ways. Odisha and Karnataka. So you can see how different states have tended to reduce that poverty headcount. Inequality has declined, which is measured by a ratio called Gini coefficient. And notice this is, we don't have income data for household, so we use consumption expenditure data to measure the Gini. So between 2011-12, our rural Gini coefficient, the larger the Gini coefficient, more unequal. And the smaller it is, less unequal. So it was 0.283 in 2011-12, 22-23, 0.266, decline. Urban, it was 0.363, 314. So both urban and rural inequalities are declining as well as the poverty. So please, don't give anecdotal type of thing. Oh, India, there is rich and poor. There are inequalities. Data doesn't support it. This is as good a data of the household survey that you can get. And this is what both the rural and the urban we are finding. Okay, so you can see how far we have to go to improve our health policy dialogue, public policy dialogue in health. And I hope that after the course, you will be able to contribute to elevating that discourse. Now, demographic trend. What do we have in India? Declining fertility, higher life expectancy. So I'm from Mumbai, and when I visit Mumbai, my relatives will tell me, "Do you remember that person? He just died. He was 87 years old." Now, when I was young, the life expectancy was in 60. 87 is just died, and is normal, at least in circles I move, which is basically middle to upper middle class circles. Living in 80s is common in Mumbai. So life expectancy is increasing. Women live longer than men. And so we have population aging. Now, what the global evidence and India's evidence suggests is that the healthcare needs increase with age. So higher share of GDP will be needed to meet healthcare needs. How do we set that aside? It's a big public policy, fiscal policy, economic issue. What should be the manner of financing this? And I'll differentiate between funding and financing in a minute. Now, notice that while we talk about India's population, we also need to know where they live, because where to locate healthcare facilities, where we need to concentrate, what we need to do. Now, notice India, many parts of India are very little population. Ganges Plain, this is where the bulk of the population is. So we need to strengthen the healthcare in this area a lot. Then we got all the coastal areas, the Ahmedabad, Surat, Mumbai, uh, some inland like Bangalore, Chennai, Visakhapatnam, Kolkata. Kolkata is already up there. So all these where we need to develop the healthcare facility. So when we are planning, the locations and the healthcare, we need to keep this chart in mind. So 50% of Indian population um, is living in here. That is where we need to concentrate. And so this is why our current policies are putting so much emphasis on developing Bihar, Eastern UP, Madhya Pradesh, Jharkhand, and so on, because this is where the population density is going to be, and they must grow faster. They cannot, if they don't grow, India can lag behind. It's as simple as that. I talked about fertility rate. Now, what is the fertility rate? It is the average number of children, statistically, that a woman produces in her lifetime. So 2.15 statistical children is when population becomes stable. A woman replaces herself and her spouse, and 0.15, some statistical, some may not conceive and all that. So 2.15. Now 2019-20, we already have for all India the total fertility rate below the replacement rate at 2. Okay. So now notice which are the states, a lot of time some of the southern states people say, oh, we have low fertility rate. So it says Kerala 1.8, Tamil Nadu 1.8. But look, Maharashtra has a lower fertility rate than Kerala, lower than Tamil Nadu. Okay. And Telangana and so on. So don't go by, again, anecdotal arguments really create low quality discourse in the country. Now, where is we have high fertility? Bihar, Uttar Pradesh, 2.4, 3.0. That's where we need to reduce. Meghalaya, 2.9. Okay, once they start reducing, we'll get this to around 1.8, 1.9 as our fertility rate. Something inconceivable, right? Fertility rate was over 5 in the 50s and 60s. This is National Family Health Survey. And this is in 1920. We are in 24. So this would have gone down further. Any question anybody has so far? Please raise your hand. I'm just setting you the context so you can understand the dynamics of the health system and its complexity. Anybody wants to raise any points? Let's try to be a bit interactive. Now, this is the this is on the India's now notice that female live longer than men, but that was not the case up to the in here where female lived less than men until 1980. So that has changed. And that changes our healthcare issues as well as women live longer. Okay. And notice one thing, we talked about statistics. These are 95% prediction interval. So they're given us the confidence intervals, not one number. Never believe one number, have a range, have confidence interval. Then there is some scientific work that has gone on. Now, I said that the health expenditures increase with age. So what is going to happen to India's population? If we take 0 to 20 years old age, in 2000, we had 500 million people in that bracket. By 2050, it will be 431. So less schools are needed, less things related to children. So it's not youth and all that we talked about again, not a very good term. If we take working age population, 21 to 64, 512 to 990. That's our demographic advantage, right? Where a lot of people will be in the working. But notice the age 65 plus, and I'm not even taking 60, which is the current retirement age. We will have from 48 million to 256 million, 3.5 times aged in the healthcare. How many geriatric specialists do we have? How many in medical system do we emphasize the diseases of age, such as Parkinson's disease and so on? Okay, so this is our challenge in the healthcare. Now, integrative local context specific. So if we have such a large number, we can't just take, the medicines are also developed in a local context. So one of the things that World Health Organization in partnership with India, or India in partnership with WHO has done, is to establish the global center for traditional medicine. Problem with the traditional medicine is that we could not trust it because there was no research studies, no scientific data, no certification, no labeling, others, and so on. This is what we are trying to overcome. So the traditional medicine is centered in Jamnagar in Gujarat. And this medicine is a knowledge center for traditional medicine. And it has a strategic focus on evidence and learning. So statistical evidence, learning, data, and analytics, sustainability and equity, and innovation and technology to optimize the contribution of traditional medicine to global health and sustainable development. So we take into account the local heritages, resources, and rights in our healthcare system. We need to integrate it. India has Ayush ministry, and there will be one resource person who will talk about the work of the Ayush ministry. WHO report highlights significant impact of Har Ghar Jal, where we are trying to provide tap water in the house. I hope you don't mind if I narrate my personal experience on this. I grew up in Mumbai in a low middle class family. in the 1940s and 50s. Now, at that time, we were living on the 5th floor. No lift, of course, at that time. And the water, municipal water, will come 2 hours at night from around 12 midnight, 1 o'clock to 2:33. We were 5 brothers. So my father and brothers will all stand on one step at midnight, will fetch the water up to the 5th story, and then once the water is done, we'll go to sleep again. That was our life. We never thought we were poor. We were respectable middle class with ambitions. Okay, so that's what our parents taught us. And but here was I remember the water. So if your water comes in tap, God, what a magnificent achievement. So think of women in Rajasthan, in UP, in other places who had to spend 3 hours, 4 hours trying to get water. Now it's in the tap. And WHO has highlighted that it has significant public health and economic savings. So they are saving life, empowering women and girls, and contributing to ease of living. This is the Niti Aayog resource person talking about it. So you can get better health, not by just medicines and that kind of thing. So you have to also think in a local context. For us, that good water and available in the house is a big health event as well. In the United States, that may not be so. So you have to think locally and understand the local context. WHO report emphasizes the tremendous time and effort saved for women and girls through the provision of water. In 2018, women in India spent an average of 45 minutes daily to collect water to meet household needs. And they overall households without on-premise water spent a staggering 66.6 million hours each day collecting water. Universal coverage through tap water provision will result in substantial savings by eliminating these needs. So by safely managed drinking water, the country could reduce deaths by 400,000 by diarrhea, prevent approximately 14 million disability adjusted years related to these diseases. And the cost savings of nearly 100 billion. So this is how we need to think in a systemic, local context specific in managing our health systems. Serum Institute of India is famous because the way the COVID, what they did. Now they are trying to double their capacity over the years. And again, being Atmanirbhar in healthcare system now with COVID pandemics used as a weapon, we have to be Atmanirbhar. Think of if we didn't have Serum Institute, if we didn't have our own COVID-19 vaccine, and we relied on Pfizer and other multinationals. How well would we have gone? So this is why national security angle is tied to the health system. Now, I'm going to summarize. Any questions so far? I hope you are beginning to understand the complexity of the and the importance of the healthcare management and governance. Okay. There is an article by Kapul and Shamika Ravi in 2017, and it's in the references I have given you as one of the readings as well. They have provided reasons why healthcare systems are so complex. So any simplistic type of definitive statements, anecdotal statements, do not do justice to the public policy dialogue on healthcare. So let me, they are analyzing Niti Aayog's recommendations to improve access. We said accessibility, reduce out-of-pocket expenditure, create infrastructure, augment capacity at district hospitals for non-communicable diseases. Why all that is urgent? So they say that Niti Aayog deserves credit for recognizing that the public sector does not have the wherewithal to meet all these challenges, and that the private sector is needed to address this gap. But there are some remaining concerns. The Niti Aayog solution is to incentivize the private sector via public-private partnership where the government provides land, infrastructure, capital for viability gap. So you just calculate how much private sector needs to become viable. There are formulas, it's fairly complicated, and you provide that. And patients via referral in the public screening programs. In return, the government fixes the price of basic services to ensure a reasonable rate of return. The delivery quality and governance of the PPPs is monitored by the project steering committee, contract management cell, and project coordination committee. The first assumption here is that if sufficient incentives were provided to the private sector through land and capital, then it would earn a reasonable return on equity, decide to enter. If so, then why not have a simpler policy? Earmark some land within district hospital or outside, provide subsidized capital to anyone who wants to enter these markets, and let market determine the winners. In PPP, too much is left for the government to decide, and that sort of reduces information. There are large fixed costs and regulatory requirements which are entry barriers, but provided reasonable returns to those who choose to enter. Here, patients will have choice, and competition will ensure that the most efficient players will survive. So they are using economic reasoning. We have a session on the economics of healthcare. Under the existing proposal, selection, monitoring, evaluation, and governance of private player is done by the government. So what they argue is government may be overloaded under the PPP arrangements. Why not try something else? Such a system suffers from two challenges. It creates rent-seeking opportunities, which will adversely create quantity and quality of care. It will attract private players with the greatest capacity to manipulate the system and not necessarily the most efficient. So we have seen that throughout India's history. In a competitive environment, performance of a firm changes over time, depending on new and better management practices and technology. Firms with dynamic efficiency survive, others stagnate. Under this proposal, The collecting continuous information on best practices, latest technology, quality of care improvements, cost reduction is left to government representatives. This is very difficult for the government to do. So notice how they are looking at tasks. Which side can do better? The second challenge relates to tariff, which is non-negotiable, fixed by the government. The biggest constraint in expanding health services is shortage of qualified human resources like oncosurgeon, clinical cardiologists, specialized nurses. These services are in high demand in big cities. In addition to higher salaries, there are large differences in quality of life between tier 1 and smaller cities. To induce migration from metros to smaller cities, players will have to pay higher compensation. With fixed tariff, this lowers profitability of the venture. So to be viable, they will do cost cutting and potentially lowering quantity and quality of healthcare. Notice how complex the reasoning is. And, you seldom see in public policy discourse on health such complexity. So that's why I was quite impressed with Kapoor and Ravi's article. The third challenge relates to key performance indicators, in particular, quality of care, health. Unfortunately, riskiness of patient is not considered when assessing quality. So good example is the IIT IIMs. The raw material is so good. It's competitive exam, the best people, they prepare. Professors don't matter. They don't add much value. These guys will do well, regardless of mediocre professors. And sometimes that is telling that IIM publications are low and others and so on. So that's a different issue, but we have to see what the riskiness of patient is. IIM, IIT students are low risk. Okay, so how much value is added? Not that much. Key is to add value. This will create two tiers of patients. Risky patients who are economically costly, non-risky patients who have fewer unscheduled visits and return to operation theater. His payment is linked to key performance indicators, which are not adjusted for risk, then private players will be disincentivized from treating risky patients while over-treating safer patients. So a lot of time you see private hospitals will sort of push away the riskier, poorer patients to municipal hospitals. So municipal hospitals are dealing with riskier patients. And so you cannot then get the performance on a comparable basis without adjusting for risk. There are also agency problems where the doctor's interest is not aligned with that of the patient. Due to lower profits, doctors avoid treating riskier patients while over-treating safer patients by performing unnecessary procedures. It's happening world over. In the United States, hundreds, thousands of medical procedures are done which are not needed on medical grounds. And we know in India too, there is a lot of unnecessary tests. This is a serious concern. For example, the latest National Family Health Survey shows that private hospitals carried out 41% cesarean sections as compared to 12% in government hospitals. Cesarean section profits are higher. Okay. Sometimes their patients are also at fault. They want cesarean done. The fourth challenge refers to payments, relates to payments, which create three types of patients: government-sponsored, self-paid, and patient insured under government scheme. Tariff for each patient is uniform, fixed, but the economic cost varies. Government-sponsored patients are more expensive. because of the rules. There are several ways for government representatives with no skin in the game to hold up the payments. For self-paid payments, funds are transferred within 15 days of receipt. Facilities therefore prefer self-paying patients, reluctant to provide same level of services to government-sponsored patients who are typically poor. Private hospitals in Delhi have reserved beds for poor patients in the subsidized land given by the government. What is the evidence from this earlier version of PPP? So we have to check and do some research. So what they are saying that it would be fatal conceit to believe simple solutions to complex problems. That's what the healthcare systems are. It's continuous reform and competence. So that's why we need to have more and more people who specialize in healthcare. Importance of affordable medicines. Pharmaceutical spending is around 1/6, sorry, pharmaceutical spending covers expenditure on prescription medicine, self-medication, over-the-counter products. Some other medical non-durable goods are also included. Total pharmaceutical spending refers to most countries in a net terms. Okay. Now, in 2021, spending on retail pharmaceuticals, those during hospital stays and so on, not included, accounted for 1/6 of overall healthcare expenditure in OECD country. So that's high, 1/6. Branded medicines have generic substitutes, but they cost more, maybe 2-3 times more than the generic ones. And that's where the Jan Aushadhi program is good. They provide generic medicines that work as well. Every time I go to Mumbai, I go to Jan Aushadhi store. It's called Pradhan Mantri Jan Aushadhi store. There are 10,000 across the country. I buy my medicines there. They cost me around 1/3 of what it would cost me if I go to a chemist. And here in Singapore, I would pay 5 times than what I paid in Mumbai in a Jan Aushadhi store. But how to create trust? I would go to Pradhan Mantri Jan Aushadhi store because I have trust. Okay, and they have a system. But I wouldn't go to any chemist who will say, "Oh, buy this." I'm traveling. I'm in Nigeria. Somebody says, "Buy this generic drug." I wouldn't buy it. Pay more for branded because I don't have trust. Bulk purchases, greater confidence generated in using generic medicines can reduce pharmaceutical costs. And our hospitals, municipal hospitals, chemists, others will need to do that. Somebody will talk about this scheme later on. There's also medical equipment that we need to, like if you have diabetes, you need the machine to measure your sugar level. If you got blood pressure, you need a machine. Everything you need a machine. So good news is that Japan's Olympus is to develop R&D hub in India for medical equipment. And it will be in Hyderabad, which will be comparable in size to its 2 existing R&D hubs in US and Europe. So that is good news, but we need to do more of those, just as we have done with the Serum Institute. So Atmanirbharta is a goal in healthcare management. Now let's look at the program structure. I've given you the introduction so far. We will move on, once this is over, to the analytical frameworks and concepts to assess the health sector. After that, we have recent and proposed healthcare initiatives from Niti Aayog. Role of Ayush approach is in India's healthcare, economics of healthcare, which I will do. Then we have a panel, fiscal aspects of expanding healthcare, use of AI and other technologies, how to enhance healthy living, better food production and consumption, and enhancing India as a global and regional medical tourism center. So that's the 4-panel discussion that will cover some specialized topic. Then we have challenges in achieving better access, adequacy, and affordability of healthcare services within India, followed by the concluding remark feedback session. Obviously, the complexity that I have explained, it's very vast. We could not cover every aspect of it, but we think that judge this program in an integrative way at the end of the program. And we hope, and at least we are confident that there will be value added for all of you. Thank you very much. Dhanyavad. So we stop this introductory session.
Thank you so much, sir, for setting such a positive tone for this course, and we are really grateful to have you here. Sir, we have few questions in the Q&A box. Should I go ahead with them?
Yes, sure.
Okay, so I'll read it out. So first question is from Omkar Babu. The reduce in fertility is due to scientific reasons or change in cultural dynamics or population control policies.
The fertility behavior is very complex because it depends on the household decisions. And household decisions get made on many variety of grounds. But globally, including in India, there are some broad reasons. One is our housing units are getting smaller and smaller. Mumbai, how big house can you afford? And how many children can you have if you got a small flat? Increasingly, women labor force participation. So difficult to have many children. Before, like, my parents had 8 children, 10, 2 died young, and 8 of us lived. They never thought of investing in us in a way that we think of investing in our children. Children are expensive to have today if you have got ambition, particularly in middle class. So people think twice before having too many. That's part of the reduction. And expectations are high. Investments are high. Not easy to raise children. Actually, at one time there was prejudice against girl child. That is reducing. Our ratio is improving. Beti Bachao, Beti Padhao. That campaign is having some positive impact as well. So I think the world over, what we have seen, that once women get control over their bodies, they are reluctant to give it up, rightly so. So before, the modern family planning ways, methods, equipment, others were not that developed. So my parents would have a lot of children. Also, many children would die. So children were insurance. Okay, some would do. Out of 5, at least 1 would do well, take the whole family along. Type of thinking was prevalent. But now that is not the case. But reasons are very complex. Okay, next one.
Okay, Ranjan Dasji, would you like to say something?
Yes, I would like to add to what Professor Mukul has mentioned. So, in fact, development is known to be the best fertility reducing agent rather than any medical or other issue.
Yes, yes.
So, once it is well known, all countries has been documented that once the development takes the pace, then automatically the fertility rate comes down. So, that would be from
Right.
my side. Thank you.
Yeah. Thank you, Professor. I
Thank
agree
you, sir.
with you.
Okay, so Gayatri Raghuraman ji, would you like to unmute yourself and ask your question?
Hello, sir. This is Gayatri. I had a question about when you were talking about risky patients. What did you mean by risky patients? Do you mean those who
Yeah.
don't pay or those who are expensive to treat? Or do you mean those who are at an increased risk of death and when they get admitted? So I was just wondering, what do you mean by risky patients over there?
When the risk of disease burden is high. Okay. So you have an elderly patient, 65 years old, who has a diabetes, who has some other things, then that person is going to be riskier to treat. There will be more visits, there are others, and so on. And on top of that, if that person is from low income and the payment is an issue, then even if government pays, a lot of time government fixed payment does not cover the full cost. So the doctors will
Yes.
prefer private patients. Okay. And that
So
would, from their point of view, will will from their point of view, they would rather have private patients to treat than the government patients. So that's the risk is of both from the
it's a combination of both.
financing payment side,
Yeah.
from the disease burden side.
Yes. Okay. Thank you, sir.
Thank you so much, Gayatri ji. Now, Neena Jolly ji, would you like to unmute yourself and ask your question?
Yes, please, Professor Das, please go ahead and add. It's such good to have your wisdom to this program.
Okay, thank you, Professor Mukul. So a risky patient is also a person, as you have already mentioned during the presentation, in the context of the third-party provider, because there are some delays in the payments. The government system or any other insurer which is paying for that patient, there is up to 18-month delay in some cases. Am I audible?
Yes, please.
Yes.
You are.
So that is also a component of the risky patient. That means when there are delays, or supposing a private hospital puts up a bill of, let us say, 50,000 or 60,000 for a 2-day or 3-day procedure admission. So in that, there will be some invariable deductions because the government has set up some rates at which we call them as package rates. And then it could be procedure related rates also. So when we apply them, there are likely to be some deductions. So that will also be one of the reasons for being classified as a risky patient. So when the patient is coming through a third-party provider, maybe the PMJ scheme or the scheme like Central Government Health Services scheme, so whatever the scheme it is, so in that the provider will put up a bill when it is a cashless method. Most of the schemes are cashless. And so the person has been treated already and a bill has been raised, but the likelihood of the entire bill being paid is less, not 100% ever, number one. Number two, there will be delay in the payment, beginning from maybe 45 days, maybe a couple of months, sometimes for complex cases, it may be even longer. So that will certainly be risky from the provider point of view. So that was one point, Professor Mukul, I wanted to add.
Yes, thank you very much.
Over to you, Tanu. Yes.
Thank you so much, sir. Nina Joliji, you can ask a question.
Professor, thanks so much. I just wanted to know that I've been working in the field of healthcare for about 14 years now, and I'm actually focusing now on dialysis and ESRD patients. So I wanted to know, like, you had developed a very good and you presented a very good synopsis of all the issues, and you spoke about lifestyle diseases increasing and communicable diseases reducing. So do you have any study which tells us that how much of increase is happening in lifestyle, which is leading to CKD and ESRD patients? And of course, the dialysis accessibility profile or availability in the healthcare system in India.
Sorry, what is your specific question, please?
My question is that is there any study, like you spoke about the Ministry of Labor undertaking the ESI, and that should be handed over to the Health Ministry. So I'm trying to work with the government to plug in this into the system for enhancing the dialysis accessibility in the healthcare system. So
Yes.
I wanted to know that is there any study available which tells us that what is the status of dialysis accessibility in India?
Okay, no, I'm afraid, I'm an economist, public policy analyst, and not in medical profession. So I do not know that part on the status of dialysis, but I encourage you to ask this question to the other resource persons, and maybe they will.
Thank you so much. Thanks.
Sorry about that.
Thank you so much.
Yeah.
Thank you so much, Neena ji. Shraddha ji, would you like to unmute yourself? Shraddha ji?
Yes. Okay, I think we do not have much time, so maybe we should move on.
Oh. Okay, sir. Now we can go ahead with the participant introduction part.
Yes.
Okay, so interaction is a pathway to generating ideas and strengthening relationships for mutual benefits. With this in mind, I would like to proceed with the participants introduction part. I invite all the participants to kindly give a brief introduction of them by raising their hands. Okay. Yeah, Swati Rane ji, you can go ahead with the introduction part.
Good evening to everybody. Thank you, IMPRI, for this wonderful program, what you have given us, a very important one today. And thank you, Professor Asher, for taking us through the whole philosophical part of health, which never anybody speaks. And also showing us the highlights, the indicators, which is very important before we start any course. So I think the start has been a very good. The foundation is very strong. And about me, I'm Dr. Swati Rane. Basically, I am a healthcare, public health and private healthcare expert. I work mainly on advocacy movements for nurses and ASHA workers. And also, I'm an activist for, hello, can you all hear me? Hello?
Yes, ma'am.
Yes,
Yes,
we can hear you.
Okay. I also work for public health movements where we are asking the government to invest more into healthcare instead of just privatizing and medicalization of the healthcare. That's a short snap of me. Thank you so much.
Thank you.
Thank you so much, ma'am, for joining us today. The participants can also switch on their videos by accepting the panelist invitation. Next, we can take. Next, okay. Omkarji, you can kindly unmute yourself and switch on your video for the introduction.
Thank you. Sorry, I couldn't switch on my video because I'm in a remote location. The network is a bit shaky here. Okay. So
No
my
issue.
sincere apologies for the same. Yeah. My name is Dr. Omkar. So, doctor, I have done my PhD in biotechnology, and for the past 15 years, I've been working in the field of precision medicine. So currently, apart from working for a company that is building precision technologies for India, I also enrolled, to one of the PhD program at RV University, where I'm working on data governance with respect to precision health and policy-related, issues with respect to this particular aspect. So that's a short introduction of mine. Thank you.
Thank you.
Thank you so much, sir, for joining us today. Next, we can take. Yes, Ranjan, sir, we can go ahead with you. Ranjan Das, sir. Okay, so participants, kindly raise your hands. Yeah, Gayatri ji, you can switch on your video and go ahead with the introduction.
Ranjan Nath sir is not able to get the audio. Then can you just check?
Yes, Gayatri ji, you can go ahead.
Hello, everyone. My name is Dr. Gayatri Raghuraman. I work as a research advisor for health at the Center for Budget and Policy Studies in Bangalore. So I'm actually usually cooped up in my office working on research projects. So I really enjoy such kind of courses because it gives me, a lot of what is going on up to date in the world outside my office. And really enjoy Dr. Asher's talks and his pointers on economics and governance. Really, my interest here really are I work a lot on health insurance and also on urban health, as well as recently a lot on early childhood. So I hope that I'll also get to learn a lot more from this course. I look forward to interacting with all of you. Thanks.
Thank you so much, Gayatri ji, for joining us today. Next, we can take Ashlesha ji. You can kindly switch on your video and go for the introduction.
Hello.
Yes.
Yes. Namaste. I'm Major Dr. Ashlesha Taude. I'm retired from Armed Forces Medical Corps Short Service Commission, and now I am a professor in community medicine in Mahatma Gandhi Mission Medical College, that is in Mumbai. I'm also a consultant for MUHS, Maharashtra University of Health Sciences, that is in Nasik, consultant in digital health. So, as a specialty, my specialty is community medicine and public health.
Yes, please.
I'm also part of both the national bodies of public health and community medicine, that is IPHA and IAPSM. I'm a medical teacher for and guide for postgraduate students in public health as well as MD in community medicine. So rural and tribal health is my a core interest area. I work in the Raigad district with tribal population in maternal and child health as well as geriatric. I was really happy that Professor Asher touched upon some of the really key points, and he brought out some of the really important highlights and insights, let me say. It's going to be helpful for me next when I talk to people and convince them regarding the healthcare, the improvement, constant improvement in healthcare. I meet people from various backgrounds, including my own students who are right now doing their graduation in MBB, I mean in medicine. It is very important that at that point of time they are raw, they are new to the profession, and they imbibe the sense of pride, and they open their eyes to the kind of improvement, the kind of progress that's happening constantly and currently in India. And even when they go abroad, probably for their post graduation or further studies, or they stay in India, they look at the health sector not as inferior or second to somebody, but one of the one of the guiding paths for entire world. The kind of healthcare programs that we are having today in India, just a few moments back, I think one of our colleagues asked regarding the dialysis. So Government of India has a separate dialysis program. um, it's a healthcare program for
Hello. Okay, I think ma'am has some network issues.
some of the
Till
participants of this course are, I think, actively working in this. So I am very, very happy to be a part of this cohort. I am also a researcher myself. So looking forward to learn a lot from each one of the participants as well as the resource persons. Thank you so much, Tanu. Back to you.
thank you so much, ma'am, for joining us today. Next, we can take Bikash Parekh ji. You can kindly switch on your mic and camera.
Hello, am I audible?
Yes. Yes.
Hi, good evening, everyone. Myself, Vikas Parekh. I am a postgraduate student from Tata Institute of Social Science, Mumbai. I have done my master's in public health and specialist in health policy, economics, and finance. Currently, I'm working as a health program strategist in Amya Arogya Sati, an NGO based in Gadchiroli, Maharashtra. So basically, why I joined this course is that I just wanted to understand how the healthcare system and governance works in the mainly in the rural parts of India, because what we see in Gadchiroli, one of the most rural and tribal district in India, it's very different in terms of whether in terms of availability, accessibility, or affordability. It's far different from what is there on the papers and in actual. So That's why I joined this course to learn more about how the governance works in the healthcare system.
Thank you so much, Vikash ji, for joining us today. Ranjan sir. Hello, Ranjan sir.
Ah, good evening, everyone, and thanks for taking us on board on this particular learning initiative. Professor Mukul Ashar has given us a wonderful overview of the entire situation, as well as the, in fact, some also suggestions how we should move ahead as a at the national level. And I am very happy that we have a mixed gathering here, beginning from young researchers to experienced doctors like Dr. Tavade and various other people. I would like to introduce myself. I am a professor basically and a researcher of 30 years standing. I was a professor at Lady Hardinge Medical College in public health for the last nearly 25 years. Subsequent to that, presently I am the director of All India Institute of Hygiene and Public Health, which is India's apex public health teaching, training and research institute. And I am also holding the directorship of Institute of Serology, Kolkata, which is looking after the elimination and eradication of 4 diseases, particularly measles, mumps, rubella, STIs in the eastern part of the country. I am also the director of port health services across Bengal. We have got 6 ports, and that the other port is in Odisha. So I am the director of all these ports also regarding the port health services. And I am also the director of state branch of NCDC, that is National Center for Disease Control, which is the agency of the Government of India looking after the implementation of IDSP as well as the IHIP portal. So eastern part of the country, I am coordinating on behalf of the Government of India. So this was my small introduction. And I am working with the Government of India at the core level, including we are having very high level meetings for the, currently we are having the pandemic issues, particularly species jumping, and we are also having temperature increase, and we are facing the very increased number of deaths related to temperature. So that was my small introduction, and I am looking forward to a great learning experience from my colleagues and from experts in the field like Professor Ashar and other resource persons who will be speaking to us subsequently. Thanking everyone, and thanks for giving me this opportunity to participate.
Thank you so much, sir. Next, I can request all the participants to kindly raise your hands so that I can call out your names for introduction. Okay. Yeah. Vishali ma'am, you can unmute yourself.
Hi. Sorry about that. I'm not Vaishali, ma'am. I joined in through her link shared by her. I'm Orko Chakraborty. So yeah, I forgot to change her name. Sorry about that. And yeah, so I am not able to turn on my camera since I'm using mobile data to tune in, and the connection is less than optimal here. So just to briefly introduce myself, I'm Orko Chakraborty. I'm 26 years old and based in West Bengal. I have completed my bachelor's and master's degrees in history from Presidency University, Kolkata. Thereafter, I have qualified UGC NET for assistant professor only in 2023. I have worked mainly in the domains of public policy and heritage with organizations such as JK Policy Institute, JK Arts Foundation, India Lost and Found, and have worked in freelance capacities with organizations with micro projects under organizations such as KaiSeed and the Global Exchange in Religion, JERIS project. Currently, I am working as an editorial assistant intern with IMPRI, Impact and Policy Research Institute, and I'm also working as a narrator intern with India Lost and Found. Thank you.
Thank you so much, sir, for joining us. Dr. Ritika, would you like to introduce yourself?
Hello.
Hello, ma'am.
Yes, hello. Am I audible?
Yes.
Yes. So, my name is Dr. Ritika. I've completed my graduation in Ayurveda medicine. Currently, I'm a master's student at Tata Institute, Mumbai, pursuing my public health in health administration. After my graduation, I worked in Gadchiroli as a senior research fellow for 1 year, and after that, I realized the system of health there and decided to pursue public health as my career ahead. And recently, I was posted at Aurangabad as a public health administration intern for 2 months. There we had to understand the overall management and governing of the public health administration at from sub-center to district level. So there I realized that some discrepancies or some lacking is there at the governing part, and hence when I found about this course, I thought I'll make use of this opportunity as I am currently in my semester break also. So that was about me. Thank you.
Thank you so much, Ritika ji, for joining us today. Lakshmi ji, okay. Amanda ji, would you like to go ahead with your introduction?
Hello, am I audible?
Yeah.
Good evening, sir. Good evening, everyone. I am actually an ophthalmologist, totally from the clinical side. I have attended IMPRI foreign policy session last year. So on and off, I attend IMPRI sessions just to get an idea about things on the other side of healthcare. And I find these quite insightful. Like example, today, sir was talking about the trust issue with generic medicines available at Jan Aushadhi Kendra. So I was thinking that is something which we also as medical practitioners face. Like when I was training, at that time of training, the rules had come in that we had to write generic medicines. And we were taught to write the prescriptions in generic medicine. And despite that, we still find patients preferring to get those particular brand medicines. So just a thought that struck me was probably if we could do something just to prove like the quality which we get of the quality of the medicines which we get from these centers is equivalent to the others, then probably people will trust, including us. So I'm just going to look into it because I have a Jan Aushadhi Kendra about 2.5 kilometers from my house, and my dad actually buys his medicines from there. So I was thinking like this is one thing which we could look into, and hopefully I'll get more insight like this through the program. Thank you.
Thank you so much, ma'am, for joining us today. Next, Lakshmi, ma'am, would you like to introduce?
Yeah, thanks, Tanu. My name is Lakshmi. My background has been in English literature and cultural studies, and then I traveled to public health. I finished my PhD, and I was working on, I was looking at historically how has tuberculosis policy changed over time in India and globally. So I have my knowledge in the politics of policy making is that's my area of interest and my area of expertise. But I wanted to, I've been thinking about learning more about health sector governance and management issues. That's not an area that I have looked at before. And so when I found out about this course, I signed up for it, and I'm really looking forward to this. Thank you.
Thank you so much, ma'am, for joining us today. Professor Pradeep ji, would you like to switch on your mic and camera and introduce yourself? Okay.
Hello, good evening, everyone. My name is Professor Pradeep Kumar Panda. I am Professor and Dean of the School of Public Health at the Asian Institute of Public Health University, in short AIPH University, based in Bhubaneswar. I am also acting dean for the School of Health Management. Basically, I am a health economist and public health management specialist, and I have done lots of work in the sector of health insurance and published a lot in many leading journals, peer-reviewed journals. And being an academician, my job is to teach, guide the PhD students, conduct the training program, and do research. So I'll talk about IUS on 29th as a resource person. Very nice and to meet Professor Asher as well as a mixed and experienced group of participants. Very nice. Thank you so much.
Thank you.
Thank you so much, sir, for joining us. Rahul ji. Next is Rahul ji. Okay. Ashutosh ji.
Hello. Yes. Can you hear me? Yes. Hi. So I'm actually working in tissue banking. So that's adjacent to the organ transplantation that happens in India, where we work in a small firm that assists hospitals in setting up tissue banks and increasing the types of grafts available to various orthopedic, plastic surgeons, dental surgeons, so that they can improve patient care and reduce the costs of patient care to prevent import of grafts that are currently very expensive from America. And I've been very happy to hear various perspectives about the healthcare sector and where we're currently headed, as this entire field is very. Thank you.
Okay. Thank you so much, sir, for joining us today. Jayprita ji next. Yeah, Neena Jolly ji, you can go ahead.
Good evening, everyone. I have an NGO called Adharshila, and this was started in 2004 after research with the Ford Foundation of NGOs all over India. So the main aim of the research document was to see what the other NGOs were doing and how to collate their effective working in the same direction and how to network with each other to achieve better results. So my organization now is 19 years old, and we've been working in the health, education, and skilling sectors. So if I talk about health, we are a ground level healthcare program deliverable agency. Like we have 3 primary health centers and we do about 26,000 OPDs in a year. So after working in all the spheres of the medical issues that the communities have, of course, we are working with lower income communities. The main focus came in some time on lifestyle diseases of blood pressure and diabetes affecting the kidneys. So that is how I was talking about dialysis, because for the last 1.5 years, we are putting in a lot of research on dialysis. And just recently, we have started the dialysis program in partnership with Ram Manohar Lohia Hospital. And basically, they are only doing dialysis for kidney transplant cases, but we are looking at partnering with other organizations, also with other government agencies, to basically enhance the capacity of any dialysis center and government hospital to increase the number of dialysis sessions. So after doing a lot of research in this, I would like to work further, and of course I'm doing it already, but I would like to do more and more in this field. So if anybody has any suggestions, please do let me know. And thanks so much. And I think I've already enjoyed the first session, and I'm sure the other sessions will be also full of learning for me. Thank you.
Thank you so much, ma'am, for joining us. Shraddha ji, you can kindly unmute yourself. Okay. Yeah. Okay. The mic is not working. I can give you introduction. So I am the market access head for a medical device company in India for 18 years in healthcare with diverse background in hospitals and insurance. I specialize in area of advocacy and inclusion of innovative therapies in private reimbursement system. So this was the introduction from Shraddha ji. Next, Rahul ji, would you like to introduce? Jayprita ji.
Good evening, everyone. I am Jayprita McIntyre. I am pursuing my PhD in the Department of Public Administration from Chennai, and my area of research is healthcare administration in public and private sector. And this is, I think, my first IMPRI session about the healthcare that I am attending. And today's session was quite insightful for me, and I'm looking forward for more. Yeah, that's it. Thank you.
Thank you so much, ma'am, for joining us today. Okay. Sir, I think we are done with the introduction part.
Right. The collective wisdom of an experience of all the people here is extremely impressive. And I'm very humbled to be a resource person for this group. Okay. What we wanted to do next was to look at the analytical frameworks and concept. One of the things we need to keep in mind is that there is nothing more practical than a sound, appropriate framework. If you have a wrong framework, which is really, reality is complex, so you try to simplify it, becomes a framework. If you have a wrong framework, the more brilliant you are, the more damage you do. So the frameworks, and framework is not a blueprint. It's an aid to thinking. So we'll talk about some of the frameworks, concepts to assess the health sector outcomes. Because a lot of time in healthcare discussions, the emphasis is on expenditure. Somebody will say India spends 3% as an example on healthcare. This country spends 6%, so we should spend 6%. It's a very silly type of argument. And all the focus is on money and nothing on the real substance. So I want to get to the substance of it. Today, we have taken far too much time on the session so far, so we won't be able to cover all of it, but I will cover some of the sections. And if there is an agreement with the director and the IMPRI organizers, we could start the next week's session half an hour early. Let me know, Arjun, if that is feasible. Otherwise, we'll fit this into one of my sessions. Okay. This session discusses analytical framework and concepts. Underlying premise is that the health sector needs to be governed and managed well and focus on health outcomes not on health expenditure. That's why we call the wellness centers to emphasize outcomes. The key trade-offs in the health sector involved accessibility, affordability, that have individual, fiscal, economic, technological, organizational competence, and adaptability, and minimizing total resource cost, that is funding, and finally, sustainability. Okay, so that is it's a trade-off. You can't have everything of everything. So how those trade-offs are made, what criteria used, that is very important for us to understand. As I said, frameworks and tools are not blueprints. They are aid to thinking about strategies, policies, specific measures. Outcomes desired are healthy population with minimization of disease burden among the population and preparedness for pandemics such as COVID-19 pandemic, just like we have a disaster preparedness agency. I don't know, some of you may know better whether we have a health crisis preparedness agency or not. Worth thinking about. An indication of health expenditure to GDP ratio in demographically mature countries. Based on latest estimate, the average OECD health expenditure to GDP ratio was 9.2% in 2022. It was 9.7 in 21. So around 9%, that is fairly high, plus pensions, which is another 7-8%. So around 15% of the GDP goes in financing that. Even that average has wide variation. So US is at 16.6. So US is a example of what not to do in organizing healthcare management and governance. Germany is at 12.7, France 12.1, and so on. Mexico and others are at a lower level. Health outcomes are not necessarily correlated with health expenditure. Just like educational outcomes are not necessarily correlated with educational expenditure. So in social policy, we need to keep that in mind and not always focus on more money as such, but on organizations deliver services. So the organizational theory, organizational change, organizational efficiency are areas that one needs to be proficient at. Per person, OECD expenditure is USD 5,000. And our per capita income is 2,800. Okay, so we have to again keep in mind as to how we put the local context, what is feasible. USD 12,555 in the US to 1,181 in Mexico. So OECD is relatively homogeneous, but a wide range. So they all do things differently with different health outcomes. While the health and social care workforce continues to grow, concern about shortages are becoming even more acute. Population aging is one reason why demand for healthcare and long-term care workers appear to be outstripping supply. High inflation has eroded health sector wages, making it harder to attract and retain health professionals. So this is a internal OECD issues. But the point that is relevant for India here is that unhealthy lifestyles and poor environment causes millions of people to die prematurely. Smoking, alcohol use, physical inactivity, obesity are root cause of chronic condition. This is something that we in India have to learn. Healthy lifestyle. wellness center, not sick center, where you go when you get sick, but you go where you want to keep your wellness. The National Health Accounts in India estimates significant drop in out-of-pocket expenditure on healthcare in India from 64.42% of total to 47%. This is still relatively high, but it's okay. I mean, we can come down to maybe around 40 or so, and we are trying to do that. So out of pocket, as we said, are borne directly. In OECD, it is over a fifth. Okay, but OECD has a different system. Here is the data. This is the government expenditure, 29% in 14-15 to 41%. It would be a little bit higher now, and 62 to 47. So we have managed to reduce. This is from the National Health Accounts of 2019-20. This is by Niranjan Rajadhyaksha, is in Maharashtra. Out-of-pocket health spending is coming down. One of the main functions of the funding and financing mix. One of the main functions of any social protection system is to provide benefits with a high degree of reliability and confidence for all stakeholders in society, particularly resident households. So we have to differentiate between funding. Funding is the share of GDP or the social resources that you devote to meet social protection in general, healthcare in particular as a share of GDP. And financing is the different instruments that are used to access funding. Financing mix doesn't affect funding. Okay, so funding is something that the society must arrange because funding has opportunity cost. If I'm spending 7% on healthcare of GDP, then that 7% is not available to do something else. That's the opportunity cost. And we have to raise that in the proper way. And financing is how we raise that. Each health system will develop its own financing mix, which reflects path-dependent choices, public financial management practices, and the social contract between the state and the people. Given the deficiencies of storing current production, the only way forward is through claim on future production. What matters, therefore, is the level of output after I have retired. The point is central. Pensioners, healthcare recipients, not interested in money. Money is irrelevant unless production is there for pensioners to buy. You may have a lot of money, but you don't have healthcare professionals, healthcare infrastructure, medicines, equipment, others. What is money going to do? So that's the, again, we have to get out of this mindset that of expenditure. So the central role, he also brings out Bar, he's at LSC, by the way. The central role of sustaining broad-based high economic growth to provide economic security for both the young and the old. If you're not growing, where will you get resources from? Then you get into not very healthy social and economic dynamics. So growth, and we all have those who desire good health policy and governance. We all have a stake in supporting those forces in society that want broad-based economic growth and not support those who are inimical to growth. Okay. Now, funding and financing mix. So health financing instruments. How can you finance commercial health insurance? Now, we got commercial firms that provide health insurance. Recently, there was news that LIC is going to acquire health insurance company, and LIC, which is a life insurance scheme, firm, will now provide health insurance as well. Social insurance from the society, tax finance programs, vouchers, medical savings account where you save, put it aside to finance medical needs, out-of-pocket expenditure, community-based program, microinsurance. So how do you finance that? That depends on the society, depends on the program, depends on, it changes and varies, but the funding remains. No health system or pension system relies on a particular instrument. So financing mix developed to reflect context-specific circumstances. Don't rely on one method. So even in pension, I tell my audiences, don't rely on your pension provider, whether it is government, employer, or whoever. Develop many wells from which you draw your retirement income. And since all of us are professionals, my own thinking is that I'm retired, but I still want about quarter of my household expenditure coming out of my professional income. Whether I lecture, whether I write, and so on, I need that income. I don't rely on one well, many wells for that. Reforms and initiatives are required to lower the direct and opportunity cost of accessing this bundle of services. So we have made transition from wood to coal, and we talked about how it reduces the health burden. Now, just a few slides on governance. Are you guys okay to continue for 10 minutes, 15 minutes, or shall we stop here?
Yes, Professor, I think we can continue for 10 minutes, no issues.
Okay, thank you. Governance.
Sorry, Professor. In the previous slide, there was something about the healthcare should only focus on the government financing system should only focus on catastrophic health expenditure and not all health. I think it was the previous slide. Could you just please discuss that a little bit?
I never said that. No, I didn't say that.
The previous slide. Yeah, the last point here. The next.
No, the previous one?
No, the next one.
Oh, sorry. Yeah.
Yes, the last point here. Could you please discuss this a little bit?
Yeah. Similarly, public healthcare program must be designed not to pay over all healthcare expenditure. So you have a dental problem, it shouldn't provide that. The catastrophic is when the household is very much burdened by the expenditure, where what we would call probability is relatively low, but if it occurs, there is a very high probability that household may be in financial distress. So that's what in the literature, the technical term for that is catastrophic expense, where household gets into financial distress. So this is Ayushman Bharat. Many people get poor in India if their main income earner has a bad health episode, which costs few lakhs. So what does Ayushman Bharat do? Allow 5 lakh per family per year where you don't have to pay. So the family doesn't get into, it's prevented from this catastrophic expense. Does that explain?
Yeah, thank you, sir.
Okay. Yeah, sometimes, sorry, I'm hurrying a little bit in here. governance of health.
Sorry, sir, I have one question. This is Gayatri.
Yes, please go ahead.
Sir,
Go
in
ahead.
your slide number 14, you had talked about reforms and initiatives are required to lower direct and opportunity costs. Can you give me an example of it, please? I didn't understand that bit.
Sorry. Yeah, I mean, we gave an example of Jan Aushadhi, right? Reduces medicine cost.
Yeah,
So
that is a
your
direct.
household budget is lowered by that.
Yes.
Or telemedicine, it reduces cost. There are different ways, use of technology, others, the organizational systems, whereby your transaction costs are lowered, and so on. I can give you another example from non-health. Before, some of your papers required attestation. Now you have self-attestation. How much money you saved?
Yeah.
Lots.
Okay.
How much time you saved? Lot. How much anxiety? Lot. So there are many, and it will come up, the examples, as we go.
Okay. Thank you, sir.
All right?
Yeah.
Yeah.
Thank you.
Okay. I think maybe we should stop here, and I'll start with governance of healthcare. Let me read this only one slide. Governance is seen as critical part of the whole approach to health systems development. But it is not the overarching framework. It is a cross-cutting theme and subset of activities focused on good governance principles and capacities. So this is the health system governance for universal health coverage report. And this is from WHO. Leadership and governance involves ensuring that a strategic policy framework exists and is combined with effective oversight, coalition building, regulation, attention to system design, and accountability. It requires overseeing and guiding the health system as a whole, not individual parts, not just the public system, in order to protect the public interest, broader than simply improving health status. So this is what we want to elaborate. When my next session comes, we will spend time on this. Okay, thank you very much. I think I really enjoyed, I don't know where over 2 hours passed since we started. I'm still ready to go for another hour and a half, but I think we should stop here. Thank you. Good night.
Thank you so
very
much,
much and
sir.
good night.
Dhanyavad.
Yeah, thank you so much, sir, for such an informative session. And we are really grateful to have you here. And we look forward to attending your further sessions here. Thank you, sir. Also, the participants who could not get a chance to introduce themselves today will be given in the subsequent session. Let's move ahead.
Okay. Dhanyavad.
Thank you, sir. So as we come to the end of day 1 of Health Sector Management and Governance, an Indian perspective, an online national summer school program, a 1-month immersive online certificate training course, I, Tanu Paliwal, researcher, IMPRI, Impact and Policy Research Institute, would like to propose the formal vote of thanks on behalf of IMPRI, Center for the Study of Finance and Economics, IMPRI, Web Policy Learning, New Delhi. We are grateful to our expert for day 1, Professor Mukul Asharji, for taking out your valuable time and giving an opportunity to the participants to learn from the certificate course. We thank all of our participants who have actively participated in today's deliberation. Reading for the session have been shared in your email, and a video of the session will also be shared with you for learning. We look forward to welcoming you for our second day of the certification course on 29 July at 6:30 p.m. when we'll be learning about India's recent and proposed healthcare initiatives and role of Ayush in healthcare systems. We are grateful if you're watching us on YouTube or listening to us on our podcasts and reading our publications. We hope you continue to join in future to our IMPRI Web Policy Talk and Web Policy Learning. Wishing you a very good evening. Thank you all.